Hello, ladies and gentlemen, and my non-binary friends. It's your boy Brandon, back at it again with another video about CCEMSA treatment protocols. So today, I'm going to be talking about the paroxysmal supraventricular tachycardia treatment protocol. We will also be covering the pediatric tachycardia with pulses protocol, as well as the pediatric PEA treatment protocol. Let's start off with SVT protocol, though, the fun one, okay? By the way, I'm here at 414 out in Mendota. I'm at the end of a 24-hour shift, so I'm a little manic right now. So, again, just like every other protocol, you're going to want to do your ABCs right off on the bat, okay? Go ahead and determine if their airway is patent, if it needs any management. From there, you can go ahead and look at their breathing status and determine if maybe they'll need supplemental oxygen. After that, you're going to want to go ahead and get started on an IV. You're going to want to do LR-TKO because you will anticipate giving drugs if this person is in an SVT rhythm. And then a big thing with these cardiac protocols is your assessment. Assessment. Okay? You're looking at CHAPS criteria, right? You're looking for stable versus unstable, whether you need to treat it with pharmacologics or Edison medicine. So CHAPS protocol, it's a mnemonic. C for chest pain, okay? Now, any sort of SVT with that sort of rhythm at that heart rate, they're going to have some sort of discomfort. Palpitations and tightness, that's not severe chest pain, okay? You're looking for myocardial ischemia type chest pain. That's what you're worried about. Okay, H will be for hypotension. So a systolic blood pressure of less than 80, that is very concerning. And then A, you're going to look for an acutely altered mental status. P for pulmonary edema, you're going to want to listen to the chest, listen for any rails. S for shock, again, hypotension, but a big one is skin signs. Are they cool, pale, diaphoretic? Do they look like shit? Do they need treatment? Now, for the stable versus unstable, they need to have at least one or more of these. One or more of those, and go ahead and just put the pads on and zap! Go with stable first, okay? So they're chilling, they're fine, they're complaining of some tightness. But they're sitting at a heart rate of 160, okay? And they've got some chest tightness. Then you're going to go ahead and consider pharmacologics or maybe something simpler like a vagal maneuver. So if they're less than 40 years old, it is safe to go ahead and try a vagal maneuver. If the vagal maneuver is unsuccessful, go ahead and do a base hospital call-in, let them know that you're coming, and request some orders. Potential orders you could get is adenosine. The orders usually come with 6, 12, and 12 milligrams. So a 6 milligram start. And then if no conversion, you can repeat with 12. And if no conversion, you can repeat again with 12. Again, you're following all of these rapid IV pushes with at least 20 milliliters of normal saline. Adenosine has a half-life of maybe 6 seconds. It quickly dissipates. So you're going to want to get that to the heart as quickly as possible. Another potential base hospital order would be verapamil. Verapamil is a calcium channel blocker. Unlike adenosine, works at the AV node. It will cause hyperpolarization of the cells that make up the AV node, which will cause essentially a systole and allow the heart to restart again. Verapamil is a calcium channel blocker. Verapamil would be a good consideration if maybe this potentially isn't SVT. At a rate greater than 150, sometimes you won't be able to tell if it's regular. And so you could be dealing with an AFib, potentially an A-flutter if it's fast enough. So that's why verapamil is a base hospital order. Consider preloading them with some calcium before you block all their channels. But the base hospital order for that one will be a 5 milligram push. Now, if your patient is too unstable to do the call-in and to start a line and to do all of this, then you're gonna have to use electricity, and it's gonna be uncomfortable. But you do have standing orders for sedation. You can give 4 milligrams of Versed, IV, IN, IM, whatever works for you. Consider 8 milligrams if your patient's greater than 200 pounds. 4 milligrams won't touch them. You also have standing orders for fentanyl. But again, if these patients are too unstable and you can't give these drugs, you're just gonna have to cardiovert raw. You're gonna want to start at 75 joules. That's the biphasic equivalent. And then if there's no conversion, also make sure you're running a strip. You're recording when you're doing the cardioversion so you can catch it and show the doctor at the hospital. If 75 doesn't work, you can move on to 120. If 120 does not work, you can move on to 200. And keep in mind, these patients are not going to want you to keep zapping them if they're a GCS 15. So consider sedation, consider more fentanyl, whatever you need. And obviously, code 3 transport, call in. Let them know what's going on. Okay? That's the SVT protocol pretty much. Some special considerations is, let me take a look. SVT is usually 160 to 210. It's a narrow QRS complex. It's regular. There's no P waves. You guys know what SVT looks like. A flutter, 220 to 350. You'll have those F waves. It might look like an SVT. So consider verapamil. Consider calling for that. You're going to want to get a good history from these patients, and hopefully they're good historians. So that's the SVT protocol. If you guys have any questions, please let me know. Let's move on to the next one. All right, let's go ahead and talk about the pediatric tachycardia with pulses treatment protocol. This is a rather large protocol. It does mention 3 different rhythms, so we're going to talk about all 3 of those, and there's different routes you can go with treating them. This I'm not going to call it an uncommon protocol to run. However, children with heart abnormalities is not very common. So again, like any other call that you show up on scene, assess your ABC. Then consider supplemental oxygen. They'll probably need some. After you start your supplemental oxygen, you'll want to get access. LRTKO with Volutrol. You're going to want to use the Volutrol so you don't accidentally fluid overload these kids. And again, assessment is big, okay? You're going to have to look at this assessment. So first you need to figure out what rhythm you're dealing with, okay? So they've got 3 different rhythms in here. The first one is sinus tach. If it's sinus tach at that rate, at that age group, then just transport, get your IV en route, call them, and try a fluid challenge. 20 milliliters per kilogram. Use the Volutrol so you can measure that out and give an accurate fluid bolus. That's your sinus tach, okay? Now, let's say we got a child in an SVT, okay? So their QRS is less than 0.08 seconds, okay? It's a narrow complex. They've got a heart rate of greater than or equal to 220 for less than 2 years old, or a heart rate of greater than 180 for greater than 2 years old. These patients also need to have signs and symptoms of some issues. Some of these signs or symptoms include delayed cap refill, diminished distal pulses, cool extremities, altered level of consciousness. These are all shocky looking signs in the child. These will help you determine whether this SVT is unstable or stable. If the SVT is unstable, then you're going to want to go ahead and use Edison medicine and do a synchronized cardioversion. You have standing orders for sedation. You can give 0.1 milligrams per kilogram of Versed, and you can give 1 microgram per kilogram of fentanyl. You start at 0.5 joules per kilogram, 1 joule per kilogram, 2 joules per kilogram, and then 4 joules per kilogram. That is for synchronized cardioversion of an unstable SVT. If the SVT is stable, then you're going to want to go ahead and call the hospital. So the next rhythm that this protocol discusses is VTach with pulses. So this is going to be a wide complex tachycardia. It's a ventricular tachycardia. The heart rate will be greater than 150 in any age group. Again, you're looking for that wide complex, that scary looking VTach. For these synchronized cardioversion, you're gonna have to use electricity. For this, you're gonna start with 1 joule per kilogram. The SVT, you start with half a joule. For the VTach, start at 1. Start at 1 joule per kilogram, and then 2 joules per kilogram, and then 4 joules per kilogram. Again, you have standing orders for Versed and fentanyl, the same dosages, 0.1 milligram per kilogram of Versed and 1 microgram per kilogram of fentanyl. Be careful giving those drugs to children. They don't take them lightly. And make sure you're doing a weight-based dose accurately. Use your Broslo tape, okay? The Broslo tape is very helpful. Also, ask mom or dad what the estimated weight is. And you should be able to take a guess, too. You have to get used to that. VTach with pulse is stable. A heart rate of greater than 150 with no signs or symptoms. Then you can go ahead and do an IV LRTKO, get a Volutrol, and you can go ahead and do your amio at around 5 milligrams per kilogram to a max of 300. Call the hospital, let them know what's going on. Okay. That is it for the pediatric tachycardia with pulses. Oh, Let's move on to the next one, shall we? Okay, next, let's talk about the Pediatric Pulseless Electrical Activity Protocol, Pediatric PEA. This is going to be a stressful call. This is probably going to be a traumatic call. There's going to be a lot of things going on. Fortunately, this protocol is pretty easy. This is your basic PALS, your basic ACLS. So start off with your ABCs, okay? Confirm that they're pulseless and non-breathing. Put them on the monitor, and you obviously will see electrical activity, but you'll have no pulses. Go ahead and begin CPR immediately. After you got your CPR, go ahead and establish a line. If it's an IV, that's great. If you see any veins, try to get that IV. If they're young, if they're less than 2 years old, then it's okay to go straight to an IO, especially in a code situation. You're going to want to go ahead and set up an LRTKO. You're going to be expecting to give drugs during this protocol. You're going to want to start your cardiotonic drugs. You're going to want to start giving epi. Your epi dose for children is going to be 0.01 milligrams per kilogram. That is the weight-based dose, a maximum of 1 milligram. And that is for 1 to 10,000 epi. You're going to want to be giving that epi every 3 to 5 minutes. And then once you have your line and you've got your first round of epi in, go ahead and start transporting. All of that stuff I mentioned previously is on scene. Take your time with these calls. You don't want to be struggling to get a line on this kid while you're driving down the road to the hospital just because you're freaking out. Stay calm, get your line or get your drill, and get your fluids ready and get your first round in. Then you can start transport. You're going to want to maintain that BLS airway. They mention it again in this protocol because you are not allowed to intubate pediatrics. So we're emphasizing the BLS airway. So a big H in children is hypoxia. So that BLS airway is very important. Make sure you're giving adequate oxygenation and you're manually ventilating. And then you're going to want to give a fluid bolus, 20 milliliters per kilogram. You're going to want to continue your epi, continue your CPR, continue your airway management, and then call them, let them know that you're coming in with a pediatric code and what your ETA is. It can be a simple short call-in. You don't have to tell them what round of epi you're on or what initial rhythm was. Just tell them pediatric code blue, ACLS in progress, be there in 5. And then once you get there and you're at the bedside and you've got the full team around you, then you can go ahead and delve into the potential cause of arrest. Some special considerations to mention for this one. Again, the common reversible causes for children is hypoxia and toxins. However, you have all the other H's and T's that you should be considering, okay? Use your Broslo, okay? I don't care if mom says baby's 5 pounds or whatever. Check the Broslo too. Compare and contrast. And besides the Broslo giving you a weight, the Broslo will also give you your doses of medication. It's a very useful tool that I would be using on these calls for sure. Remember your epi every 3 to 5 minutes, just like, ACLS and PALS. I'm sorry. If the child is greater than 3 years old, you need to try at least one IV attempt. If they're less than 3, go straight for the IO. Okay, it's a cardiac arrest scenario. You don't need to mess around with it with an IV and a baby. And remember your pediatric triangle, your assessment triangle. I have a note right here. We've got appearance at the top. We've got work of breathing, and then we also have skin signs. Okay, you're going to be looking at their respiratory rate and effort. You're going to be looking at their skin, assessing their circulation, and just their general appearance. Is it a floppy baby who's not reacting? Is the baby crying? Is the baby happy? These things will give you an indication of whether you have a sick kid on your hands. So for these 3 protocols, that's about it. I went ahead and covered the SVT, pediatric PEA, and pediatric tachycardia with pulses protocol. I recommend reviewing them and studying them. These are difficult protocols, and these are good protocols to know off the top of your head when you're on scene. If you guys have any questions, please let me know. And I'll see you guys in the next episode of CCEMSA Policies and Procedures Treatment Protocols. Goodbye.
Departments, but in other practice or usual practice, a 10mm syringe blowing just hard enough to start moving the plunger, we believe gives a similar sort of pressure. Right. So you ready? Mm-hmm. And ready, steady, blow. And the benefit of that is that patients can use this at home and outside of the hospital because it's a condition that can recur, and that gives the patient some control and may mean that patients don't need to come to hospital in the first. We're cardioverted to sinus rhythm, whereas for the modified technique, 43% of patients return to sinus rhythm.
You're doing really well. Good stuff.
that really does demonstrate marked improvement.